Good evening, and thanks to everyone for joining us today. On behalf of Nari Division of Jackson Pal Pharma and the Fembon Division of Jackson Pal Pharma, we welcome you all to the webinar today, which is organized by Haryana chapter of ISAR. We present to you Cystilia M, formulated with the ideal ratio of 40:1 of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Divatron SR 20 mg micronized and sustained release tablets of dydrogesterone to improve compliance and enhance outcomes. Divatron 10 mg tablets are also available. Lycorid M tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage, Lycorid M contains two proprietary complexes, natural lycopene as lycobeads from Israel and L-carnitine and L-tartaric acid in the ratio of 2:1 to give highest available L-carnitine as Carnipure, which is sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. To refer to the webinar in future, you can visit our YouTube channel, Jackson Pal Medical Insights. We now invite Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR, and Director Roots IVF at JJ Institute of Medical Services, Sciences, Bahadurgarh, to kindly initiate the program. Over to you, ma'am.
Yeah, thank you so much, Jackson Paul. Thank you, Dr. Deepika. And a very, very happy Holi to all of you. Tomorrow we are going to have a Choti Holi, and next day we are going to be playing with colors. And hopefully this festival of color keeps bringing colors to your life, to your dreams, and to your patients. So with those positive thoughts, we bring to you this series of Inspire and Ignite on behalf of ISAR Haryana with our tagline of Prayas Evam Vistar. And this is the 13th series that we have together. We have been bringing to you on this platform, and this is by the embryology team of our Haryana ISAR, whose conveners are none other than Dr. Ved Prakash sir, Dr. Shilpa Marwa, and Dr. Praveen Upadhyay. So they have a big thank you to Dr. Ved sir, who has really made such a beautiful program, and for infertility specialists, embryologists, something we always look forward to, and we should be knowing at least the basics of it so that we can sync and we can be on level with our embryology team. So keeping that in mind, sir has charted a beautiful program, and with the blessings of Dr. Ameet Patki sir, our national president, our secretary, Dr. Asha Baxi ma'am, we are constantly making our small steps towards excellence. So Dr. Amit sir, the Medical Director of Fertility Associates Mumbai, the consultant Khar Hinduja and Surya Hospitals, and presently our National ISAR President, sir is a real support to all the chapters, and especially we really, whenever you need and whenever we have any advice to take, sir is available even on one call. Thank you so much, sir, for being with us. And our secretary, another beautiful, dynamic lady, Dr. Asha Baxi ma'am, a consultant at Asha Baxi Fertility Center. And she is a vice president of FOGSI in 2022 and a founder chair of MP IAG, MP ISAR, a recipient of many awards, who is always we always relate with you whenever we have any issues. So we have a wonderful team at the national level to support us at our chapter level, where our team of Secretary Dr. Meenu Handa, Clinical Secretary Dr. Manju, and our Treasurer Dr. Lakshmi is there. And then our Vice President, Dr. Rakhee, is always there whenever we need her whenever, for all webinars, she is with us, and our second Vice President, Dr. Anupma. So thank you, our Haryana ISAR team, and today for our chairing the first session, we have Dr. Charu Joshi, who is our chair, who is the president for our national team representing the embryology section. He's the chairman embryology ISAR, has experience of more than 20 years in embryology. His doctorate in life science, medical director, Genes India ART Bank, Indore, and also the lab director of IVF unit at Ujjain Medical College. Sir has been the past president of Academy of Clinical Embryology India, and he is co-founder IHERA. Thank you so much, Dr. Charu, sir. You again are another one person, wherever needed, whenever needed, you are there and always guiding us. Thank you for joining today. I know you had another parallel webinar, but thank you for taking our time to be here as well. And then we have our another chairperson, Dr. Rimmy, who is from Chandigarh, ISAR. I don't know whether she's joined us. She's director Singla Medical Clinic, and she's president of Mohali Obs Gynae, and also the treasurer of the ISAR Chandigarh chapter. Then we have Dr. Rakhee Malhotra, another chairperson for today's talk. She is director ASK Fertility, Rohtak, Haryana, and she is a recipient of the Golden Aim Award, and presently she is the vice president of the Haryana chapter of ISAR. So, do we have Sir's Dr. Hetal's CV? Yes. So, can I request Dr. Rakhee to please introduce our speaker, and then we will have, after the talk, we have Dr. Charu Sir's comments for the talk.
Good evening, everybody, and thank you, Dr. Jyoti, for giving me this opportunity. She's hats off to her for a dynamic and a brain with beauty, and she's a mentor. I've become the mentor of so many inspiring ISARians, Haryana ISARians. And it's an honor to introduce Dr. Hetal Shukla. He's a laboratory officer from October 1996 to January 2009, and a production of frozen semen for artificial insemination embryo transfer technology in IVF, OPU in cattle and buffalo. Management of Nature Conservation Department of Presidential Affairs, United Arab Emirates. Reproduction biologist, multiplication of Arabian Tahar, and Nova IVF Fertility Center. Presently, he is there as a chief andrologist, and managing andrology lab, structured training of new andro tracks, IUI workshops, and other in-house workshops to train and update the andro tracks. So he has been helping so many people for this way. And welcome, Dr. Hetal Shukla. Yeah.
So thank you very much, ISAR Haryana, for giving me this wonderful opportunity. And thank you very much for the very kind introduction. Without wasting any time, let me proceed for the today's presentation on advanced sperm selection techniques. Now, the first question when we think about sperm selection comes, we need to explore so many options, conventional to advanced. Why not need semen? So fundamentally, sperm will lose its functional capacity during prolonged exposure to the seminal plasma. It inhibits capacitation and acrosome reaction. Simultaneously, into the seminal fluid, dead sperm, leukocytes, everything produces harmful reactive oxygen species, which may adversely affect onto the DNA integrity. And removal of microbes and prostaglandins is also one of the important concern why we are not using neat semen sample. Yes, the spermatozoa plays very important role in fertilization process. It penetrates zona pellucida, fuses with the oocyte and achieves fertilization. Low sperm motility or abnormal morphology, ICSI is used directly injecting a selected sperm into the oocyte. As I have briefed this, why we don't use knit semen, there are three major concerns about it. And spermatozoa playing a 50% role in entire formation of embryo, and it has genetic integrity is also one of the important factor which we need to ensure uh, before selecting the sperm. Implantation and pregnancy success, also motility and poor sperm quality may contribute to the recurrent implantation failure as well. So starting with conventional sperm selection methods, probably everyone knows about density gradient and sperm swim up. Yes, swim up, as we all know, selects highly motile spermatozoa by allowing them to swim out of the seminal plasma into the sperm culture media. And it is very simple, cost effective, but this may simultaneously discard some of good sperm as well. Density gradient centrifugation separates spermatozoa based on density isolation, motile and morphologically normal spermatozoa, effective for moderate male infertility, but it may induce DNA damage due to the centrifugation mechanical force that is applied onto the sperm cells. So these are conventional methods. Some of the advanced sperm selection techniques which I have listed here: PIXI, physiological intracytoplasmic sperm injection, which reduces DNA fragmentation by selecting mature spermatozoa having better DNA integrity. Magnetic activated cell sorting will remove apoptotic sperm with high DNA fragmentation. It helps in cases of recurrent IVF failure, poor embryonic development. Microfluidic, which is talk of the town everywhere nowadays, is also it mimics the natural selection process in female reproductive tract, which isolates high motile spermatozoa, which is non-invasive in nature, reduces DNA damage compared to the conventional methods. IMSI, which uses very high magnification, beneficial to severe teratozospermia and recurrent ICSI failure. Zeta potential selection, based on electrical charge of the spermatozoa, sperms are selected. Electrophoresis, again, sophisticated version of the zeta potential method. And AI also are nowadays motivating everyone to go for. There are some softwares coming up which which helps in selecting sperm for injection based on the AI analysis. So starting first with PIXI. PIXI is a physiological ICSI where high hyaluronic acid receptors on the spermatozoa binds with high hyaluronan that is coated onto the surface of the PIXI dish, and where bound spermatozoa bound showing motility. So in this case, only motile spermatozoa. This technique is useful only with motile spermatozoa, and they will show binding with the PIXI dish, I mean hyaluronan bound surface, and this can help. The results with this technique is very variable. Bonded sperm, sometimes embryologist finds difficult to separate from the surface, but yes, it has shown some very good improvements with the embryology and ART outcome as well. The other technique, which is a magnetic activated salt sorting, where apoptotic spermatozoa programmed cell death is known as apoptosis, right? This occurs during the spermatogenesis. If cell damage is showing some DNA sperm fragmentation may appear due to this. So this one, the healthy cell will have phosphatidyl serine which is internalized, I mean inside the cell membrane, right? And you can see my cursor moving. Plasma membrane, which is showing PS, that is internalized. Now with apoptotic cell, this PS is externalized. You can see this dark blue one. So this PS is having an affinity to bind with annexin beads. And these annexin beads, which are of the diameter of 50 nanometers, they have a specific antibody which detects these markers of PS externalization. And these annexin beads are on a magnetic means supramagnetic beads. So when they are passed through the magnetic field, the apoptotic spermatozoa will remain into the magnetic field, and the good healthy with intact DNA will pass through and will be eluted, collected in separate tube, where you can use them for the therapeutic purpose of IUI, IVF, or ICSI, anything. So, in a way, this is a very scientific methodology which helps to select, rather, it deselects all the apoptotic sperm, and healthy spermatozoa can be utilized. So, this technique is indicated for low sperm quality, high DNA fragmentation index in case of high DFI. A high degree of HOS negative sample also can be subjected to this technique. Patients having undergone more than 2 cycles without achieving pregnancy can also be subjected. Repeated miscarriages, smoking, alcohol consumption, and IMSI can be complement to the MAX technique, where it enables to choose the best sperm for fertilization. This technique selects spermatozoa that do not have a special marker indicating might have an alteration. This is a MAX protocol. I am not going into the detail, but yes, it may yield a better quality of embryo, resulting in a very good healthy pregnancy. There are some evidences which supports nanotechnology based approach, which provides safer enrichment of spermatozoa with the base sperm. Uh, One of the study where I found an interesting conclusion, which was PIXI versus MAX, abnormal sperm DNA fragmentation in ICSI cases. This study has concluded MAX is preferred when the females are younger than 30 years, while PIXI is preferred in older females. Uh, uh, Moving on to the very widely talked about is the microfluidics technology. This is now several versions of the devices are available. This was primarily, which I saw for the first time, was this device. And now many, but the fundamentally this technique is based on the motility, the progressive motility, as we are showing the sperm. When seeing when sperm is moving, it has some, I mean, progressive, fast and straight, but having showing some turbulence into it. So there are this technique is focused onto the sperm to select based on to the motility. So microfluidic devices, when when researchers and the commercial people, when they think of microfluidic system to be brought about, so they want to put maximum of FRT. FRT is female reproductive tract, whatever, how best it can be mimicked with. So, there can be active sorting of the spermatozoa, or either passive sorting of the spermatozoa using microfluidic sperm sorting. Active sorting is based on the rheology of the spermatozoa. Rheology is the a spermatozoa moving against the fluid flow, and passive sorting is based on the shape, size, and the electrical charge of the spermatozoa. Whereas the third kind of sorting could be possible, maybe either with two chemotaxis or thermotaxis. These are temperature gradient or chemical gradient can be incorporated into the system. So these are all the considerations which can uh, mimic the female reproductive tract and help the sperm help us to select the best spermatozoa. Mechanism of microfluidics, I think the microchannels are there, and there are two kinds of fluid flow. One will be laminar fluid flow and the other one will be turbulent fluid flow. So turbulent fluid flow depends on fluid characteristics like viscosity, density, and velocity, and the geometry and size of the channel. That leads to the calculation of value that is known as a Reynolds number. I'm not going into the depth of the physics, but yes, flow within microchannel becomes streamlined and predictable at the micro scale. Fluid behavior becomes increasingly governed by the viscous forces and surface tension, which can be described as the cohesiveness of the liquid's molecule. But this figure will tell us the spermatozoa having high DNA fidelity will show left swimming or right swimming, and they will be collected into the channels of the microfluidic device as shown in the figure. Whereas DNA breaks, the spermatozoa having DNA breaks will move straight, and that will not be used at the end of the procedure. So there are several evidences available to say that this reduces SDF and it helps in selecting good spermatozoa. Moving on to the zeta potential sperm sorting into the ERT procedure, the spermatozoa normally have a very natural negative charge, which is around minus 16 to minus 20 millivolt, due to the presence of glycosylpho phosphatidyl ionositol GPI anchored sialoglycoprotein CD52. This is acquired during the epididymal transit, and this negative charge allows spermatozoa to bind to a positively charged surface, selecting mature spermatozoa that has intact DNA. So as we are seeing the tube, positively charged tube surface, spermatozoa are kept inside, I mean semen, and then centrifuge. And during this centrifugation, negatively charged spermatozoa will stick to the positively charged surface, and that will be separated after the centrifugation and will be used for the procedure. Advantage of the method is it is simple, cost effective, and rapid selection, improves XCI outcome when combined with density gradient. The disadvantage is low sperm recovery, limiting use in oligospermia cases. The sophisticated version of zeta potential, I believe, is electrophoretic sperm separation. And here, as we can see, again, negatively charged healthy spermatozoa migrates to the positive electrode from the separation membrane. And in the next image, the device we are seeing is it is uh, still not commercially available. Probably it is still under validation. It is from Australia. This device may come and help for electrophoretic sperm separation for the therapeutic process. The other technique, which is very probably less known and less known used also, is sperm heads birefringence. The spermatozoa are selected. ICSI is performed under the polarized light. The principle to understand this, how this technique works, is one must know pycnosis. What pycnosis is? Pycnosis is nuclear shrinkage and chromatin condensation, which is often associated with cell death. Now, what happens here is the spermatozoa showing non-pycnotic nuclei are selected, uh, which shows birefringent head, and will be selected for the ICSI procedure. So, as we are seeing here, this is the sperm A, B, and C. So, the acrosome reacted in spermatozoa A and not reacted in B. C is devoid of birefringence because of the absence of a conventional sperm texture. So, with a vacuole in its head. So only non-pycnotic nuclei can be birefringent, and because of this organization of nucleoprotein strictly packed in a very compact texture, the spermatozoa will be showing birefringent, will be selected for the ICSI procedure. So lab and clinical outcome by the study is visible here, and it has shown some improvement, though it may be non-significant, but it shows improvement with the lab outcomes. Hypoosmotic swelling test is also used for severe asthenozoospermia or absolute asthenozoospermia. But one of the interesting, everyone knows about hypoosmotic, so I am not going into the details of it, but what important evidence I could see and I would like to share with every one of you is the host coiling patterns are shown in this. So they are classified in A, B, C, D, E, F, G. So A pattern is the host non-reactive, I mean dead spermatozoa, and B, C, D, E, F, G, they were tunnel stained, I mean for DNA integrity. After tunnel staining, in tunnel staining, positive staining means they are showing DNA fragmentation. Now, if you see the graph, pattern A, or which is dead spermatozoa, is showing highest positive staining, whereas D and E pattern, which is this one, so that D and E pattern showing the least positive staining means giving good DNA integrity with D and E pattern of the host. So if you calibrate these patterns and select wisely with the pattern type of pattern for the ICSI procedure, probably it may yield in a better quality of embryo and better outcomes. IMSI is the procedure using magnification of more than 6,000 times magnified morphologically sperm. So motile sperm organelle morphological examination is carried out. So ICSI versus IMSI, you can see the difference, and selection of the healthy, I mean morphologically normal sperm can be selected and used for the procedure. But here the results, literature says results are almost at par with ICSI. So considering expensive, probably this is not very commonly used. Going to the automated sperm selection software, sperm selection software, that what it does is it captures videos of this motility, and the spermatozoa, the movement is analyzed with linearity and velocity and all other parameters. This, and based on these analysis, the software will rank the quantitative score of low, medium, good, and best. And based on that, as you are seeing in the image, spermatozoa A, spermatozoa B, and spermatozoa C are graded as so priority wise sperms are means software will tell the priority for injection will be given to the sperm A first, B to second, and C will be the last priority. Like that, but this selection is based on the uh, motility parameters of linearity, velocity, and all. So, based on that software analysis, this helps us. So this publication shows the use of software. I mean, sperm selection with the software and without software ICSI performed. Uh, all the parameters, all the outcomes are non-significant, but they are showing some improvement. Non-significant improvement is shown there. One important this review article, they have analyzed this listed techniques, and 47 studies were reviewed, and out of these 47 studies, as you are seeing, 30 studies have shown improvement of ART outcome. And if you see bifurcation by technique wise, so this IMSI PIXI microfluidic max, if you see, max is showing 85%. I mean, 85% of the total studies are showing improvement, whereas microfluidic is showing 2 out of 3, which is 40%. PIXI is showing 7 out of 10, that is 70%. 12 out of 11, 21, that is IMSI, showing 57%. So just this gives an idea of efficacy of the technique. Let us have a review on one of the Cochrane review also. In this Cochrane review, HAXE versus standard ICSI was compared, 8 randomized RCTs, max versus ICSI, zeta potential versus ICSI, and electrophoresis versus ICSI. Live birth and miscarriage rates, or live birth clinical pregnancy rate, and lower DNA fragmentation and lower recovery rates were compared. Somewhere it is, I mean, as you can see, for HAXE and standard ICSI, no significant difference in live birth, miscarriage rate, or reduced miscarriage. Max versus standard ICSI, uncertain impact, and miscarriage rate, no significant reduction. Zeta potential increased live birth rate, but clinical pregnancy rate was also higher, but needs validation like that. Electrophoretic sorting, faster selection, 6 minutes versus 40 minutes with DGC, lower DNA fragmentation in selected sperm, lower recovery rate compared to DGC. This article has summarized semen alteration and suggested protocol. So once you see what is the semen picture, teratospermia, asthenospermia, oligospermia, what could be the better option with which is available to you, which can be subjected what. So this helps us when this is very recently published in 2024 only. So non-obstructive azoospermia with FSES, asthenospermia, teratospermia, you can see these are listed techniques. So yes, it can be like that. So here I'll again, due to the time constraint, probably I will not go into the detail of everything. Advantages, disadvantages, description, and clinical outcome and all are listed. Probably we can have some. So just to conclude, I would say for mild to moderate male infertility, Swim up and DGC are simple, effective, but may not be suitable for cases with high DFI. So for high DNA fragmentation and recurrent IVF failure, max Pixie, microfluidic sorting, electrophoresis, and SID software may provide refined sperm selection. For severe teratozospermia, IMSI may be helpful. For unexplained infertility and recurrent pregnancy loss, Pixie, microfluidic sorting, electrophoresis, zeta potential may improve embryo quality and implantation. For high precision and AI based selections, softwares may be helpful. Each of these techniques has its strengths, limitations, and the best method depends on the specific infertility, case, indication, etc. So thank you very much, ISAR Haryana, once again. Thank you everyone for listening me peacefully. This here I have specifically placed this robot because within a view we are thinking of advance. Just a lighter note I am telling. We are always thinking some advancements. Probably future will be robotic only. Thank you very much.
Uh, Thank you, Dr. Hetal. As usual, it is a wonderful talk, and we really enjoy it. Before that, I would just like to say a few words about our President and ISAR Haryana activity. It is, I want to congratulate Dr. Jyoti, Malik and entire Haryana team chapter to organize such wonderful webinars series in last few months and in a year. I am seeing this, and this is going very well. And as per our president policy, they are always in support of embryologists, and they are giving more focus on this kind of webinars, and there is a full support from Central Research. The second thing I would like to say here is that now this situation is changed, and the embryologist and the role of embryologist is also very well recognized in the field. And the third important thing for which Dr. Hetal Shukla has explained the entire talk about this semen is that patient, when it comes to the clinic and is ready to do everything whatever you suggest, and still if conception is not there, then there is a big question why it has not happened. And probably from last few you may say a couple of years, the semen is given its due importance, and it is very broadly analyzed, and now the specific tests and investigations are also performed. So this is really a nice topic, handling of gamete, which is very important. So now over to you, Dr. Hetal. I would just like to mention here, as a simple practitioner, infertility practitioner, if I am doing regular semen analysis, what all latest techniques or the techniques which you would like to include in our daily routine, which gives us a better idea of the semen sample, like this microfluidics and all, this is for the specific purpose when you are performing any ICSI or any procedure in the lab or something. But in routine, if you have to offer something new in the in semen analysis, like DFI and all, what all are your suggestions to get incorporated, which is easy to perform and cost effective also?
Yes, sir. For as far as semen analysis is concerned, DNA fragmentation, I would say, is very widely, broadly accepted, and most labs are performing sperm chromatin dispersion test. Apart from that, high aluminum binding assay is also available, and high aluminum binding assay where HA binding spermatozoa are quantified, which can be incorporated. Hypoosmotic swelling test can be incorporated, and now sperm mobile like media are also available, which can be used for the to see the potential of spermatozoa where severe astheno, zoospermia is prevailing.
Yeah, but like all these tests, do you have any set of conditions or in this condition only this test should be performed, or this you are suggesting for in general routine for normal semen analysis also it
No,
can?
sir. Sir, see, host and sperm mobile or pentoxifillin like test are indicated for asthenozoospermic patients only, severe or 100% asthenozoospermia. DFI and HbA, I would say indications are almost same and common, where recurrent failure of, I mean, entire IVF cycles are failing, embryonic development is observed poor, some extrinsic factors or lifestyle uh, factors are also found with the husband, smoking, alcohol, exposure to the pollution or something like that. So based, if my insistence will be, the labs should be focusing on collecting lifestyle data as well when they are collecting the semen sample. I would say that if that is also brought into the routine practice, it may help to go further with
Yeah,
this.
and just one last thing I would like to know your opinion about. Like nowadays, we are having specialized labs available, like for genetic testing, we have various specialized labs, and for other reasons also. So, do you feel that andrology or for performing an every analysis, you need a specialized kind of laboratories specialized for andrology test only? It's a requirement.
Sir, I would say, rather than going for specialized labs, I would insist of specialized training of the androtechs, and their quality control. I mean, their analysis and everything. The quality control, external quality control, should be emphasized more, I would say, because human interference is always going to be there, and machine of course will help, but the expertise which is descended through training will be a great tool, I believe.
Thank you, Dr. Hetal. It's a nice talking to you, having a good discussion. Over to you, madam, for taking it further. Thank you very much.
Yeah, thank you so much, sir. Thank you, Dr. Charu, sir, for bringing up this topic, about the androtech especially. So we need to have more and more people being trained so that at least we are thinking of AI, but at least we should be first, ourselves, we should feel secure, and we should be having
Why?
much better
Why?
knowledge so that,
Yeah, why I have brought this point is because till now semen analysis is like just count and motility for everyone. As an infertility practitioner, what we used to see is just count and motility. But now it has been very well established that it is much beyond count and motility. So an elaborate semen analysis may help us in diagnosing the exact problem and giving the better outcome.
Yeah, very true. Yes.
absolutely, sir. Wonderful talk, Hetal sir, and we really enjoyed. Though we know the sperm selection techniques are so many, but I think still at the end of it, exactly which one do you prefer? That would be my just question, a very short question from my end.
Uh, so see, I would say, first, we have to see which technique. See, birefringence and other techniques. I mean, zeta potential and are, they are just into the discussion. So, widely used and widely available techniques are Pixie, IMSI, Max. These are the,
Microfluidics,
so
microfluidics are you using, sir?
which one, ma'am?
Microfluidics.
Microfluidics, yes, yes, we are using. Yes, yes, we are using.
Right.
Yes.
Okay. So
Micro.
I think we move on because we still a lot of wonderful, again, another good talk and then wonderful panel discussion is. So thank you, Dr. Charu sir, for your words of wisdom and for words of praise and words of support for Haryana ISAR.
Thank you,
We
madam.
thank you, sir. We go on to our second talk, for which I invite our chairpersons, Dr. Gurneesh Singh. Dr. Gurneesh is a senior infertility specialist, and he has been the professor of Maharaja Agrasen Medical College, Agroha. He has approximately 2 dozen papers being published at various national, international levels, and he has served military hospital as a gynec, and then he has served MAMC Agroha as assistant professor, associate professor, and a professor. And he's now presently also the president of the Hisar Obs and Gynae Society. Welcome, Dr. Gurneesh. Then we welcome Dr. Praveen Upadhyay. He is Director, Kamna Fertility and IVF Center, Gurugram. He is also the Professor, Head of Department, Clinical Embryology of Shikohabad, UP University. He is a certified senior embryologist from the American Society for Reproductive Medicine and also has done an advanced diploma in ART and reproductive medicine from Kiel, Germany. And he's also a master from Singhania. He's Master of Science in Clinical Embryology, Singhania, Rajasthan. He's also convener of our Haryana ISAR. Welcome, Professor Dr. Praveen Upadhyay. Then we have our next chairperson is Dr. Anurag Bishnoi, Medical Director, National Fertility, Hisar, Haryana. And he's done his master's clinical embryology from UK, has a vast 20 years experience and has done 18,000 plus IVF cycles and has 6,000 plus pregnancies he has provided at the single center, and he is working for gender equality and right to motherhood at all ages. Welcome, Dr. Bishnoi. And then the fourth chairperson, our own Secretary of Haryana ISAR, Dr. Meenu Handa, who is also the Clinical Director, Unit Head, Cloud9 Golf Course, Gurugram, also the ex-Unit Head of Fortis Bloom IVF Gurugram, and the North Zone Coordinator of FOGSI Endocrinology Committee. So over to Dr. Gurmeet sir for inviting our speaker, Dr. Nidhi Singh.
Thank you, Dr. Jyoti. It is indeed an honor to be invited to a webinar. Now coming to Dr. Nidhi Singh. She is MBBS, MD in Anatomy, DNB in Anatomy, DC, M&Ms, AMSA, Medical Director, Tejasvi Women's Wellness and Maternity Center, Varanasi. She is Consultant Embryologist, Financial Hospital, Varanasi, Assistant Professor, Financial Institute of Interdisciplinary Research and Education Academy, Varanasi, co-distributor of Genes India ART Bank Varanasi branch. She has got a teaching experience of more than 18 years and multiple national and international publications to her name. She is team member of IHIRA, that is International Human Embryology Research Academy. I invite her to please present her presentation.
Thank you so much, sir, for the kind invitation and introduction. And I thank Dr. Charu, Joshi, and Baxi and the whole ISAR Haryana team for inviting me here. So the topic allotted to me is quality assurance and quality control in ART lab. We all know, like just now, Hetal sir has very nicely depicted all about andrology, what the machines are used, what the benchmarks were there, what we were aiming to get a good sperm at the end. So what all these things are, there should be something which is controlling the outcome, the result. That is what we are going to discuss in this presentation. So coming to, just give me a second. Yeah. So what is total quality management system? what we aim? We aim that whatever we are doing in our IVF center or the IVF lab, we have an outcome which will be giving us something in relation to maintaining high standards, ensuring compliance, and achieving consistent results when we are doing it. So what do we aim out of this when we are doing all those things? It improves our patient outcome. And secondly, it ensures safety and effectiveness of all the lab procedures which we are conducting in our lab. Now, if you see this, this is a very, very depicted diagram. Everybody knows about it, that everything is there in the culture system, the laboratory, the patient, the outcome. But I just want to emphasize QC, QA is a very important part of it. So what is total quality management? If you see, it has sub-units under it, that is quality assurance and quality control and something else. So what do you want to see? If you see quality assurance and quality control, it is not only associated with the IVF field, the ART lab or the IVF hospital. It is associated with hospitals, the machineries, the industries. It is also associated or related in our school system where we want quality assurance and quality control. So this term is vaguely used everywhere. But what do we mean about it? If we see comparing the two terms, quality assurance is process oriented, quality control is product oriented. What is the outcome? If we compare the quality assurance, the defect prevention is done. In this, defect identification is done in quality control. Next, it's a proactive approach in quality assurance. It's a reactive approach in control. It is a managerial tool, whereas quality control is a corrective tool. And finally, quality assurance is responsibility of everybody involved in our IVF system, the whole lab, even also the outside the lab, the whole of the IVF unit is involved in it. But the quality control is mainly specific to team. That means if we talk about the ART lab itself, the embryologists, the team embryologists, the andrologists, and the team members and the juniors, they are involved. So what is extra? There is quality improvement. It's an ongoing process of identifying, implementing opportunities of enhancing lab processes, their efficiencies, and their outcomes. This is the third term which is coming forward. So the key points which I'll be enhancing today are, number one, quality, where we'll be discussing ultimately the outcome we want is good quality gametes, good quality technical culture system, and good embryos which are formed. Then quality assurance is what covers in quality assurance here is recording all quality checkpoints which are there, whether there is proper documentation and assessment done. Also quality assurance, there is comparing same with the previous month, documenting implantation and pregnancy rates to see the outcome. Whereas next coming is the quality control. In this, what we'll be doing is the daily checks, that is checking the gas, the temperature, the water levels, the media of the pH of the media, the checking the gamete quality, checking whether proper sterilization techniques are there, whether we are achieving those rates or not. And finally, whether the quality improvement in which we will be striving to improve the culture techniques, we will see what we can do to get better and good quality embryos. So talking all about quality, there is something known as quality cycle, as you can see here, also known as Deming cycle. So what it does, it is the simplest and commonly used quality implementation methodology that encompasses continuous quality improvement as well. It enables both management of the quality system as well as its execution. So what do we do? Simply in this foot picture, if you can see, we plan, SOPs are made, identify there changes have been seen where they can be implemented. SOPs are made according to the lab which you are having, the workload, the patient load which you are having. So these SOPs are according to that. What culture media you're using, what culture system you're using, what incubators are using. So we plan. Then we implement these scales. We do testing of these skills, whether whatever we have implemented, whatever SOPs we are forming, are they giving us better results? Then we check whether the results which are coming are up to the mark, that is measure them. And finally, we act, whether it is a positive outcome, whether it's a negative outcome. This cycle is a continuous process. Now, coming to the guidelines, there are various guidelines which have been discussed. The Asha guidelines is there, the ICMR guidelines is there, the RBMO guidelines is there, ASRM guidelines. Also, ISAR's consensus guidelines on safety and ethical practices in IVF is present for all of us to see and implement. I'll just emphasize few points of the ASHA guidelines in which was recently given, and what are the key points. The first point which I want to point out is whether we are ensuring the person who is doing the process is qualified and competent enough. Secondly, SOPs which are used, which are validated and properly written. Thirdly, ensuring the full traceability of the gametes, materials, equipment, and also the embryologists and the persons who are present in the lab, whether we are able to trace all the steps or not. Next, confirming all the media, disposables, everything is proper quality, they are tested. Ensuring proper and periodic equipment maintenance, service, and calibration. Next is verifying conformance to specifications, whether they are done or not. Next, taking corrective actions. Now, this is very important. Taking corrective actions if the procedure is there, whether we are getting the outcome satisfying us or not. Then reviewing the performance to ensure continuous and systemic QMS improvement. And finally, providing risk management. How do we achieve it? Practically in the lab, how do we achieve it? So I have very simply demarcated it into two parts, that is internal quality control and external. So what comes under the internal quality control is our daily checks, which we are doing as an embryologist. Usually we we ask the junior embryologists to do it so that they have a good follow-up and learning curve. And we should also make sure that we are doing it weekly so that we are doing a quality control check on them. So what are they? Their temperature check, CO2 check, and VOC check. This is normally done. And monthly, or some people do it quarterly, the swab test for the culture system, whether there is any growth or not present. Now, what is external quality control? External quality control when we are taking or we are requesting or we are recruiting another validated company who is coming, bringing their own equipments to see and check and validate whether our lab is optimally functioning, all the parameters are correct, and whether our devices which are giving us, which we are doing temperature check, CO2 check daily, they are giving us the right result, and we are not in a confusion that, in a blind spot. So this is known as external quality control. So what comes? They are usually done quarterly or half yearly. Particulate, what do they mainly target? So recently in my lab, this was done. So a very nice question which I asked them was simply, what do you mainly aim? So the main aims they pointed out was particulate count, whether the filters are working fine, integrity of the filters, the VOC count, the pH of the media, hygiene of the lab, and finally the calibration, whether all the equipments are calibrated up to the mark, including the devices which we are using for testing. So this was their gadgets and tools which they bought, the suitcases, which all these devices are there for the checking of pH and VOCs. I'll be showing you simultaneously. Now taking one thing at a time. Starting with laboratory setup, the facilities which are there, and the air quality. If you see, the IVF laboratory must have adequate functionalities to minimize any damaging effect upon reproductive cells and to pre-implantation embryos. In short, if we see the position or the placement of the lab, if it is placed on the outskirts, if it is placed in a very busy area where the pollution level is very high, whether construction is going on or new construction site is there. So these small matters where the placement is there is very important. Also, placement refers to, along with the placement and setup, refers to the patient load which is coming to the lab. Next, control temperature and humidity, whether it is maintained or not. I'll be taking it later. Materials free from VOCs. All the materials which you are using in the lab, they should not have VOCs, including the painting of the lab, the setup of the lab, the stools, chairs, everything which you are using. The facilities should have separate washing area. Specific clothes should be worn inside and outside the laboratory, and sticky mats should be there so that when we are entering the lab or exiting the lab, we don't carry germs or infection inside the lab, and they should be restricted entry. Simple as that. No other person should be brought into the lab just for getting an exposure or just for seeing, come on, let me see what is happening. You should have a very, very good strict rules and regulations followed regarding the entry, especially by the embryologists, senior embryologists. And finally, clean room and adequate air quality, which is because of the presence of the HEPA filter. So you can see the ISO guidelines. It is saying more than 0.5 micron particle should not be present in the lab. Now I have got these devices which were used in the lab, in my lab, by the quality control team. So I'll play this video. I wanted to show you something. This placement was done inside the laminar. I cannot, just a minute, sorry. Give me a second. Is it visible? Okay. So I just see when in the laminar there is all the values are 0. Then the person brings his hand in front just above the machine, and suddenly you will see that there is presence of, you can see the VOC levels will suddenly rise. You can see here. Just observe for a second. We'll just bring the hand inside the laminar. I don't know why it's not working. And suddenly the levels are raised. I'm sorry, the video is not working very well. So I just want you to note that the VOC count should be less than 0.5 parts per million. And one important point I wanted to point it out, that the VOC meters which you have purchased in your laboratory, you should take care whether they are parts per million or parts per billion, because it matters what particular side it is counting for checking the VOC. Now coming to the next term, that is personnel, that is a team which is doing all the procedures. The number of the laboratory staff should be dependent on the number of cycles performed per year. There should be sufficient qualified personnels. Regular training and education should be done of the persons. Healthy work environment. Backup for the laboratory staff should be available. As very lightly pointed out with Charu, Joshi sir and Hetal sir, that embryologists should be trained into the newer techniques which are coming rather than formulating the old ones. And the training is a very, very key important point to growth of the lab. Now coming to the processor, it should be, even though the SOPs are made, SOPs are typed and printed, we have to take care that these SOPs are implemented and whether they are followed through and whether the outcomes are benefited with the following of these SOPs. If it is not, SOPs are usually lab-based. So make your own SOPs. Don't divert too much from the standard procedures, but you can be comfortable according to the media which you are using, whether you are using one-step media, whether you are using culture media, differential culture media. All the SOPs will vary lab to lab. And also one more important thing, the SOP should be reviewed periodically. Next are the equipments. The laboratory should contain all essential items required for IVF in a number appropriate to the workload of the patient which are falling through. The equipment should be calibrated, working condition should be checked, periodical maintenance should be done, downtime should be further recorded and notified whether the repair is done within the time limit, or if the repair is not done, whether there is some alternative instrument which you can use for the procedure. And finally, if the downtime is more and the repercussions are following on the cases, so this has to be very, very importantly taken out, especially when you're having one incubator in your lab and you're doing patient cases. So always make sure that you have 2 incubators. A backup incubator is a must in nowadays. Now coming to consumables and disposables, everybody knows it that the consumables should be MEA tested, LAL tested, they should be CA certified. We should ensure that these consumables and disposables are delivered in a proper condition. They are not broken. The quantity is not, handling should be proper. The quantity should just not be overloaded inside your own lab also, so that if one packet is open, everything gets infected. So you have to take care of all these things. And the most key important point is, whenever you are receiving, whether it's a consumable or the media, you have to take care to check the number, the key number which is present, and secondly, the expiry date. So we are not landing up using expired media or expired consumables. So this is the key points. Coming to the temperature in the culture system, everybody knows this temperature is 37 degrees, and we have seen so many studies which we say that there is slightest change of 0.2 degrees Celsius of temperature can lead to various and very, very bad outcomes to the gametes. Now this is a thermocouple which is used for measuring. This is the case system in my lab where we were using the thermocouple to measure the temperature. The probe which is in the front part of the thermocouple is dipped inside the culture media dish, which is kept for equilibration and temperature maintaining. Now coming to the next, that is CO2 and O2 levels. So these 3 factors, that is the temperature, the CO2, O2 levels, and the pH, they can be done on regular basis in the lab itself. Now, CO2 level, we all know it from 5 to 6% CO2, and the O2 level should be less than 5 or less than 5. Now, again, I'm not going into the depth of this too, but everybody knows the key point, the CO2 level, it's dependent on the pH, which is maintained in the media, and it changes from the altitude of the center which it is placed. If you go into the higher altitude, the CO2 level will be changed. If you're going towards the seaside, the CO2 level will be changed. So we have to take care, the CO2 level should be maintained such that the pH is within the limit and there is no damage to the embryos. So we can do the sperm survival test to check it. The pH, what we want to attain is 7.2 to 7.4. And again, it is important that pH checking is, every center does not have a pH meter. So these external quality controls play a very, very major role if you're doing it quarterly to come and check the pH of the media. Also, which company media you are using is important because the pH at which they give the best result is mentioned in the protocol. So these key points you have to keep in mind. Remaining, everybody knows about it, that the adequate number of incubators should be there according to the caseload, as I have talked about. Limited door opening. If you have one incubator and you're landing up doing 10 cases, the number of door openings is so much that you will never be able to calibrate your media to a level where the pH is 7.2 to 7.54, because again and again there is loss of CO2 and there is increase in O2 whenever the door is open, and that cannot be done if we are having a lot of cases in a single incubator. So make sure if your number of caseload is increasing, please purchase a new incubator simultaneously. Also, the culture media for the media and the oil should be incubated overnight. And lastly, we should have all the labs under monitoring so that if there is an alarm in view of the CO2 or any problem is there, the CO2 levels have gone, the gas cylinder is over, the alarm will be ringing, and we have to take care that those alarms are followed through. These are the various methods and the recent things which are coming for analyzing the pH. The benchtop pH meter was there earlier, then blood gas analyzers were used in many of the hospitals, and the recent most is the real time. So what are the steps or when you should actually do the pH testing? That is, you should do it regularly. When there is a new lot of media, if you're changing your media, if you're changing your company, you should always take care that you do the pH testing. Then there should be new premix tanks are used. When you're using new gas, we are using a new vendor. Again, they have to be seen. And after the incubator maintenance is done, this is again very important. Now, coming to the next parameter is a checklist. Now, checklist is mandatory to be put in the lab at the start and the end of the day. We check basically for every variable which is happening in the lab and whether they are landing up into the optimal range or not. We also check the variables that are not automatically monitored by the instruments. Like the incubator can monitor the CO2 level and the O2 level and the temperature. But what about the other things? Finally, anything which has been monitored, seen, should be documented and recorded. The next thing is the sample identity and traceability. Now, this is not the part which is only related to the ART lab. It is going beyond the ART lab. It begins from the time when the patient is entering the IVF center, what is the system with this, it is properly identified. You're giving a UHID number is there, allotted to the wife, to the husband. Then all the procedures which are being done, have they been monitored? They should have a unique identification code. Also, direct verification of patient identity is a must. All devices containing biological material must be clearly and permanently labeled in the lab, also in the pathology lab, also in the endo lab. And also the if you have an automized electronic system, which is recently witnessing system has been added, it is a boon for tracing of the materials and the patient. And finally, coming to emergency plans. When something happens bad, when something happens wrong, troubleshooting is a key role which is to be played, and we have to follow through all of them. So coming to the emergency planning aims to describe the action to be taken off for safety of personnel and patients. We have to take care that the protection of all fresh and cryopreserved human materials is there. If there is any fire, if there is any calamity which is happening, which is not within our control, it is beyond. So we have to take care. The first thing we say that we have to procure and secure our cryotanks. That is the first thing. And finally, limitation of the damage to equipment and medical records. Obviously, we have to protect the tanks, we have to protect the embryos, but also the coding, the marking, the medical record, they play an important role for tracing of those embryos. So these all things have to be taken care. We should always have a backup. Nowadays, everything is digitalized. The documentation, even though we have a hard copy, we always produce a digital copy, and those digital copies should be stored at the cloud so that if anything happens, we can go back and we can check what we are having. We don't lose things. And these records have to be taken up for a long duration of time. Now, all these we have talked about calibration, equilibration, we are checking these things, we are doing quality control, but there should be some standardization to which we are seeing whether this quality control is achieved or not. So two wonderful consensus were brought forth, that is the Vienna consensus and the Maribor consensus. It's a very big consensus and a very big discussion in itself, but I'll take the crisp of it. So what they are doing is they are basically seeing the two issues. That is, they are seeing the competency value and the benchmark value. So what is it? Basically, competency is that when we are doing a procedure and we are achieving a certain standard, which we think, okay, we are competent enough. We are within the limit and our efficacy is good. We are judging that. But benchmark is something which we want to attain and which is the best. If you are saying, for example, I'll take a simple example. That is, we talking about the IUI and IVF preparation, sperm motility preparation, the competency level is 90%, whereas the benchmark is more than 95%. So this is the key KPIs which you're talking about. Now, we have discussed about competency value, benchmark value. Everybody knows this chart here. But what are the few rates which we use in very daily and practical purpose every monthly, which have to be seen? If you say all these are mandatory, all these are important, I will not say that is a single rate which is not to be followed. But if you ask me what are the key rates which I want to see the sudden outcome, the embryo quality is saying, the embryologist is good, the results are good. So these are the key points which I'll be taking into consideration. That is the ICSI damage rate, which talks about the competency of the embryologist itself, the failed fertilization rate, that is the case related, the cleavage rate, whether on day 3 the embryos are cleaving or not, which is again, if you trace back, it will help us to see our culture system, the day 3 embryo development, the blastocyst development rate, and finally the implantation rate, which is implantation of the cleavage embryo or the blastocyst. We don't usually go for the clinical pregnancy outcome because clinical pregnancy beta positive rate is also very significant, is the main part which we are taking as at the end of any IVF cycle. What is the outcome? So we see the beta positivity rate. Now coming to pregnancy outcome, if we say pregnancy is not just beta HCG positive, if I'm talking about the clinical aspect, pregnancy outcome correlates with the whole of the duration of 9 months, where a lot of variations are there, the maternal factors are there, the environmental factors are there, which also play an important role in the growth of the embryo and the growth of the baby inside the mother. So for this, I've brought the Maribor consensus, which is related to the clinical part also. So here, what the important rates which I felt was to highlight are the cycle cancellation rate, which depends on the system followed in the IVF center itself, the rate of OHSS, whether the drug, the number of drug, the amount of drug dosage which is given, which is calibrated, is it correct? If you're having a lot of OHSS cases, then we should step back, see what drugs we are using, what severity of the OHSS is there, and how we can prevent them. Coming to the proportion of M2 oocyte rate, this is very important because M2 oocyte rate, if you're getting lots of OCCs, but the M2 rate, conversion rate is very less compared to what we are expecting. Depending upon the AFC count and the size of the follicle also, it plays a very important role, because whether the trigger is given rightly, whether the temperature control of the drugs is there. If you trace back, if there's some problem in the M2 conversion rate of multiple cases, you should take a step back, see the control of the temperature control, whether the drugs which is coming from the manufacturer to the IVF center, in the IVF center to the nursing station, and from the nursing station, how they have been instilled. So these steps have been taken if there is something related to the drugs. Coming to the next is again, I'll take these 3, which are the outcomes, that is complications for OPU, the clinical pregnancy outcome, and the multiple pregnancy rate. These again bring down the results which we are taking part. So this is the clinical part which I discussed. Now coming to the future trends in QMS for IVF. Now, as I have already talked about, automation plays a very important role, and AI is the next thing. AI-driven analytic for predictive maintenance of equipment and real-time monitoring of the lab conditions is been implemented in majority of the laboratories in India itself. Now, automation of routine tasks is done to reduce the human error and increase the process efficiency. Also, there are predictive analytic programs for improving the IVF outcomes are there. They are marking the drugs, they are marking the time of retrieval, they are marking the time of trigger. These predictive analytical programs are helping to tailoring a better treatment plan. And also these evidence studies which are showing, they're helping to improve the IVF success rate. So what is my take-home message? I'll say TQM is a necessity. SOPs are a must for everybody. Every center, every lab should have their own SOPs. Quality control and quality assurance is not a one-day thing. It has to be done regularly. It has to be done periodically. And it has to be done meticulously under the guidance by all the seniors are involved. And finally, KPIs are our guide, which will tell us whether whatever we are doing, whether we have good equipments, good environment, good culture system, good embryologists, but the results are not there. So KPIs will guide us whether everything is running smoothly. So the best practice is there for the best result. And finally, thank you. And a very happy Holi to all of you from my end.
Thank you, Dr. Nidhi. You spoke very well and almost covered the whole topic. But there is slight difference of opinion with me. Like I say that clinical team should also be taken into consideration whenever you are going for QA and QC.
Definitely.
And especially when we say that we are like, I have got a small center and a lot of small centers. So when the media lot comes, so you are always remain in network with other centers also. If that media lot has not given good result in one, be sure that you yourself are cautious enough to do it. Then again, like I said, if the clinical pregnancy rates or anything changes when the lot changes in any of the surrounding centers, then we should be in contact with the clinical team that भाई वहां हुआ है तो ऐसा नहीं है कि हम बहुत तोप है कि हमारे नहीं होगा. Almost protocols, media, everything is almost same in surrounding centers. So these are the few points I wanted to emphasize.
Rimmy, sir, you have rightly said it, sir, and very, very well said it, sir. Because we always, I believe, especially to make friends, we say we make friends because, sir, everybody is using, majority of the people, we are a small knit family of embryologists and gynecologists who are in this field. And the lot system, even if you complain to the company, there is something amiss, because I have traced all in troubleshooting. Basically, what we do is we have to go back and see all the steps. Whether during that time the CO2 monitoring was there, whether cylinder change was done, nothing should be away from the normal. If there is, then, and the first culprit, like for the embryologists, we always blame the culture media. It's very easy. So, and they will say, ma'am, this culture lot is there, we are supplying to. So we have to make sure that we get the person who they have supplied the same culture lot, get a review from them, because we cannot only depend on their outcome. I'm not saying that they are saying us wrong or they're saying, they will get back to us because they have to defend their media, sir. And you have very rightly said, sir, that we have to figure out who is using. That is why I said two important points when you receive a consumable or a media, that is to see the lot number and to see the expiry, sir. So what happened at my center itself, and I've seen what when we're taking the culture media, that is the main one-step media we are going for, or sequential media, they have a very short duration of 6 weeks, sir. So what they're doing 6 weeks to 2 weeks that they're taking for supplying the media from outside to India, and then only 4 weeks duration. So we have to take care if we are doing the cycles are having a lot of gap in between. So make sure the media which we are using, we are ordering less media, and we are not reusing the media which has been open more than 7 days or 6 days now that they're saying. And secondly, this check, the time check, sir, is very important. So we should also note, we have a register here, which we are using when we are opening which lot we are using for which case. If you're opening on 15th and 21st, the second media lot has been opened. So when we trace back, it becomes very easy. If we have used this lot number. So you have rightly said, sir. And clinicians are in the small center or big center, they are always involved in the QAQC, sir. It is never key they are segregated because we have to answer to them, sir. So it's we are a team, sir. It's like that.
Thank you so much, Dr. Nidhi. I mean, definitely QAQC is something which is the heart of the IVF lab, without which our rates will definitely, I mean, without which we cannot give the success to our patients. So very well explained, and definitely the heart of any lab is that you have to continue, and it is not just one day process, it is daily, every day, and it is an ongoing thing. So thank you so much. Thank you, our chairpersons. And now move on to our important, very interesting panel discussion on the good IVF practices to optimize embryo development. And for this, we have our moderators, none other than Dr. Ved Prakash, sir, who's a scientific director at the Sperm Life Advanced Embryology Lab of Delhi. He has been working as a regional head of embryology north in the Nova, South End IVF. Also has worked as a lab director South End Fertility in IVF from 2000 to 21. He is founder International Human Embryology Research Academy. He has been the past president of ACE, and he has been a member of the Virtual Education Committee Society for Education of for Study of Reproduction. Sir has he has been a faculty at various places, and also we are thankful to you, sir, for being the convener for the embryology committee of our Haryana ISAR. Thank you so much, sir. And our second moderator is Dr. Nancy, who is a senior consultant embryologist at the Department of Reproductive Medicine, Jindal IVF and Memorial Nursing Home. She is ASRM certified embryologist who has done embryo and blastocyst biopsy training from Embryology and PGD Academy UCL. She has done her embryology certification course from IFS, Indian Fertility Society, has an experience of 9 years, presented multiple papers, has been a PhD scholar and postgraduate in the molecular biology, and a team member of International Human Embryology Research Academy. So over to the moderators, so you can introduce the panelists, and we move to this interesting, very pertinent, very important session. Thank you.
So today we are going to discuss about the best practices in IVF lab for optimizing embryo development, and we'll try that you take home some valuable insights. For that, we have an incredible panel with us, including Dr. Shilpa Marwa. She is a chief embryologist at Grace Fertility, Gurgaon. She is expert in ICSI, PICSI, embryoscope, TESA, PESA, and all the ICSIs included. Welcome on board, Dr. Shilpa. We have with us Dr. Devendra Patel. He is Chief Embryologist, Sunflower Women Hospital, Ahmedabad, Gujarat. He also have medical master's degree in biotechnology of human-assisted reproduction and embryology from IBI Foundation, Spain. He is working in the field since 2007. He is nominated as a mentor in ASHA mentorship program from 2022 to 23. Has done various invited oral and poster presentation in number of national and international conferences. Has published various papers and chapters as author and co-author. Welcome, sir.
Thank you.
Next, we have Dr. Vikramjit Singh. He is lab manager, Cloud9 Hospital, Gurgaon. Then we have with us Dr. Paresh Makhwana. He is ASRM certified embryologist, IVF lab director, Nova Wings Hospital Group of Hospitals. He is also executive committee member of ACE India, advisory committee member of IFS, Yuva team leader of IHERA, and he is also on various editorial boards. He's published various papers and is invited faculty in various national and international conferences. Then we have with us our embryology chair, Dr. Charu Dutt Joshi sir. He has a doctorate in life sciences. He's medical director in Genes India ART Bank Indore. He's also lab director IVF unit RG Birdy Medical College. He's a consultant embryologist, also past president of ACE and co-founder of ISAR. Welcome, sir. Then we have with us Dr. Rahul Sen. He is Chief Consultant Embryologist and Lab Director, Neelkant IVF. He have various awards and honors under his name. He has Appreciation Certificate by ISAR Haryana, ISAR Shining Star Award Embryology in 2023 Ahmedabad, IFS Achievers Award, IFS National Conference 2022, and he has leadership roles, various leadership roles also, past ACE Executive Committee member from 2019 to 24, former treasurer of ISAR Rajasthan, former executive member of IFS Rajasthan, also invited faculty at Amity University and Rayat Bahara University, Chandigarh. He has various publications under his name, and right now he is affiliated with ISAR, IFS, ACE, IHERA, Asha, and EFS and GAF, and also organizing committee member and team member of various international and national organizations. Welcome, sir. I think Dr. Karan Vadera is not with us today. Okay. So without taking further ado, I think I should start sharing my slide. My slides are visible?
Yeah.
Okay.
Yes, Nancy.
So as I said that today we are going to discuss on good IVF lab practices to optimize embryo development. So we have our panelists with us, and so there are numerous international and national guidelines and recommendations on best practices. They all emphasize on how to handle precisely how to handle the embryos precisely in the lab, how strict quality management system should be, and how to have a controlled environment inside the laboratory. So these are the all guidelines. Dr. Nidhi has already elaborated and explained about it all. So now, without taking any moment, I think we should start taking our questions. So we'll get into each one of it step by step, starting with the people of embryology, the embryologist and the team. So my first question will be how does lab staffing impact embryology lab? And what's the single most overlooked aspect of embryologists training that can directly impact the embryo culture system? Deven sir.
So yeah, it is very important to select first the selection of the right staff. That is most important. And second thing comes after selection, the number of embryologists. So I think a lot of labs do not have the required number. So starting from QAQC till late evening vitrification and all the procedures are covered, and majority labs are working with less number of staff. So sometimes you have to work on Sundays or public holidays also. So I think staff in that sense is very, very important. And coming to your second question, that is the most overlooked aspect of the training. So I think training is very, very critical part of the IVF laboratory. Because if you train perfectly, then obviously it is going to help you in the long run. And the person rightly trained is definitely going to help the embryo culture system indirectly and give us the very good results. So training should be in both the ways. Like you have to talk to the trainee also that, okay, you are doing right in this particular area, and then you are going to next step. So there are definitely validation processes there. You validate and then go to next step. If that person is not getting validated in particular step, you have to help him or her and then try to improve. So I think you have to go stepwise in training.
So I think Dr. Devan, you are very good, well pointing out about the staffing. So there is one more connected question with that. How you decide how many cycle per embryologist you need in the lab?
Uh, so this is really difficult question in Indian perspective, I can say, because internationally there are a lot of Miss ASRM or ASRA has given the guidelines. So normally, what I consider is like if there is at least 30 to 35 cycles, then we should have at least 2 embryologists and 1 andrologist separately. And with every 25 to 30 new cycle added, you should increase 1 embryologist. So this is what the norm I like to follow.
Good. Anyone? Paresh, would you like to say something?
No, I am agree with Dr. Dev Patel. Actually, what happened in India scenario, what we're doing is number of cycles is increasing, but number of embryos are not increasing. So what happened that is causing some extra burden on the embryologist, and then that is definitely going to affect or result. So when we consider the increasing number of the embryologists, we can consider with the number of the cycles also, but we should take focus on the what are the process we are doing, what are the procedures like. Training of the staff, like our documentation. We also need one extra dedicated staff for the documentation, because we know that nowadays the documentation is the biggest burden on us. So we should increase staff according to the processes, and definitely with the number of increasing cycle.
Rahul, you are visiting so many centers now on Nilkant. There are so 3-4 centers you are handling. How you manage that staff over there?
So basically, what Nancy has mentioned here as a question, that what number of embryologists, the number is, I think, very well defined by Dr. Devin. And the other aspect is the training. Yes, training is important. Training not only on the single aspect, like that they have been trained, but regularly checking, regularly assessing, and regularly monitoring their KPIs in terms of how they are doing, how they are developing their own skills. That is again important. And this to be done either on weekly basis, either on monthly basis, just to increase the efficiency of embryologist also, and just to increase the efficiency of your embryology lab, that how the embryos are being made, how the culture systems are working, how the atmosphere of laboratory air or whatever QC patterns are going in the lab. And with this, qualification of an embryologist is a must concern in terms of legal aspects of ART. So yes, embryologist itself with the number, their training, their regular assessment, and how they are doing and developing their skills in the lab is again of an important aspect. And all these parameters cumulatively can give you better outcomes, not only with the embryologist, but also with the lab with the lab.
Dr. Charu, would you like to summarize all of these?
Yes, definitely. I would like to summarize this. This is a very relevant question, and in today's scenario, this is very important. See, basically, the best part of IVF or infertility or being embryologist are like is that there is no emergency. Everything can be planned well in advance, and accordingly, you can manage the staff. Accordingly, you can manage the cycle and all. So right now, as rightly said by Dr. Devan, Dr. Rahul, that the number of embryologists, as we all know, there is minimum requirement of 2 embryologists should be there in the lab, in any lab, irrespective of number of cases. And then later on, as many number of cases increases, you can keep on adding. The important part here is that you have to keep a training program always running, because the person coming to your lab working for you as an embryologist may not be aware of the system in your place. So in-house training is must. So what they can do is that after joining, they can just offer 6 months only observation or 6 months under trainee kind of program, and then they can be given fully independently charged, because need of embryologist is there. There is no doubt about it. But unfortunately, we don't have that much trained embryologists here. So just keeping 3 or 4 or 5 embryologists for namesake in the lab is not going to work. So we need to give specific training to them, and then they can start working. And in Indian scene, we have to see the number of cases as well as number of embryologists available. And I think that's the important part, irrespective of number of cases. Like if we ask about independent person, independent embryologist per day working in the lab and can handle the cases, so I feel he or she should not do more than 4 or 5 cases in a day. That is good enough. Otherwise, stress factor will come into picture, and then the quality of the work is compromised.
Even I think 4 cases are too much for one person, because
Yeah, but
he has to do
it
documentation also. If something missed in between and documentation part, that will create a big problem.
Why I said 5 figure is because, say, for example, from 9 to 5, if you are working in the lab, I think 5 cases you can manage, you can do the documentation with planning. That is what in the first thing I said, that there is no emergency. You can plan the time of pickup accordingly, you can plan the cases accordingly, and it can be done.
Can I add one thing?
Yes, sir.
Yes, please.
Yeah, so because I had done a lot of trainings, I would always prefer whenever fresh graduate come for training, I used to prepare a calendar. So maybe that calendar maybe for 1 year, then it will be having a proper demarcation that for first 3 months you will be doing some basic training. So basic in the sense andrology, paperwork. Then you go to next level. So maybe ovum pickup, and then vitrification is like advanced training. So then if it is a structured program, it is good for the person who is trainee and the person who is a mentor. Both knows what is going on and what should be done for the improvement. So the complete course is known by the trainee also, because in most of the center this is very unknown. Like it depends fully on the lab manager. If lab manager decides, okay, I want to put this person in now ICSI, he or she will put him in ICSI based on whatever the decision is there. So that is not structured. So I would always like to do a structured training. So then I would love to put them in a calendar. So that calendar is there in the lab also. So everybody knows what is going on with this particular training.
Very well said, sir. And this takes us to our next question. As sir said that there are different roles of embryologist, lab manager, which takes us to the next question. What are the basic roles of the lab manager? How does a day in the life of IVF lab director looks like? What are the roles? What you have to do? How you are managing other embryologists and the people under you inside the lab? Let's start from Dr. Shilpa.
So IVF lab director, his work is a blend of various procedures and aspects, from high-end decision making to procedures analyzing what other junior embryologists are doing, or what other senior embryologists or their teams are doing with and also troubleshooting, plus procedure analyzing, documentation, KPIs. So I think the most burdened person in an embryology lab is the IVF lab director.
Anyone? Dr. Paresh?
So the days of sorry, I was actually disconnected. The IVF lab director is very busy in a full day, since morning to since evening, or I can say for 24 hours, because we have to take care of each and everything of the laboratory. Like we have to observe each and every process of the laboratory, from andrology to embryology. We have to take care of all the documentation they are going on or not. We have to take care of our staff, they are getting trained or not. We also have to check that what are the SOP we have made, the SOP they are following or not. At the same time, we also have to follow our own process what we were doing before. That means I can say as a lab director, we have to do all the work from trainee to the lab director. Like we are it is not like that after becoming a lab director we have to just made SOP. We too have to do ICSI, IMSI, biopsy because of the certain cases. So the day of the embryo, the lab director is very hectic.
Dr. Vikramjit, are you there?
Yes, sir.
Yeah.
Sir, for me, first thing what I do in the lab, first I go and check all the data which is entered, like for daily QAQC, like what was the temperature of the instrument, what was the lab temperature, and how was the VOC was there on the Then after that, I move to the embryo grading sheets. I go through each patient's embryo culture, how the culture is proceeding. Then after that, the third works, what I do, I look for the OT list, the cases which are posted today, then how we are going to do the sperm washing, then how the cases, how the particular procedure will be done. All those discussion will be there with the team. And at the end of the day, media preparation is there. So if I have to see every dishes, like most of the dishes I see, like what is the height of the oil and everything. So how the juniors are preparing the dishes. So these are my routine days of in IVF lab.
Anyone want to add something?
Okay, I would like to add one thing. So I would like to be present in the morning when the embryo grading is done. So okay, maybe some junior or maybe some other embryologist or even senior embryologist is doing the grading. I may not be doing, but then I would love to be present when the grading is happening, because that time you may be able to know what is happening with the, like, if pH is wrong or maybe the quality of gametes are poor. So lot of information you will get when you are present during the grading.
Yes, of course, it is very important thing to check all the gradings, the junior or senior, how they are doing, and how they are mentioning in the document sheet. Because on the basis of grading, you can plan your ET, which embryo to be transferred or not, which embryo to be freeze or not. So it is very well said. Thank you. Next.
So which takes us to our next question, the workflow. It is very well known that quality management system plays a very important role, but there are other things also which are important when we start a layout of the lab. Whenever you plan a lab design, there are what are the key mistakes lab makes in layout planning that could negatively impact the embryo handling and the staff performances?
Rahul, recently you have made 3-4 labs.
Yeah.
I think you can explain your experience over here.
Yes, I think as what this question has mentioned, it has answer in it only. Like what we can actually look for, that in what aspects or in what areas there can be some mistakes. So whenever we are having some changes or whenever there is some modifications in SOP is seen, and in this particular SOP, like for example, there is a modification in SOP of ICSI was seen. So there can be a chances of having mishandling of gametes, mishandling of embryos, or in any cases where there is
So
a
I want to stop
embryologist.
you here, Rahul. This is regarding the lab design actually.
Okay.
So we are talking about lab design. How your plan your lab design? What are the mistakes we can do in that lab designing?
Okay. So from the designing part, I think one must need to understand in what areas and in which areas you are keeping your sterile zone and compared to with non-sterile zone, because your embryology lab doesn't start with the embryology lab itself. It starts with the surrounding areas, what surrounding areas it is nearby equipped with. Suppose an embryology lab is just attached to an operation theater, what chemicals, what equipments, what procedures are being done in that operation theater. Again, that is of highly implicable results with your embryology also. And where is your scrub area? Where is your changing room? Because many of us embryologists take care that they will not wear any kind of jewelry or perfume, but there are the other team members also. We have to segregate these kind of these departments. What is the flow of air, how air ventilation is there with the sterile zone and with the non-sterile zone, because again you have to think about the VOC aspects also, that there should not be accumulation of foul air inside the lab or inside the sterile zone. All these parameters to be taken care of. And when designing the finally designing with the embryology lab, there should be adequate spacing patterns, and the spacing of equipments, where the laminar is to be kept, where the incubators to be kept, how the door will open inside or it will open outside. All these parameters to be planned, checked and verified before implementing or before constructing the lab. Because this particular flow, this particular pattern of getting into the lab, how an embryologist will going to be working inside the lab, this will again have an huge implication. And this will not only have the huge implication in his or her working pattern also, but also in embryo outcomes also. So I think all these parameters need to be overlooked very carefully, because we are also legally bound to have sterile zones like operation theater, embryology lab, semen preparation room, semen collection room, and all these rooms or all these spaces necessarily to be present or to be available in the premise itself. So yes.
Dr. Charu is there. Dr. Charu, are you there?
Yes, sir. Yes, sir.
So Dr. Charu, you are visiting so many labs, doing so many freelancing over in past years, at present also. So can you tell us few major mistakes in labs they are doing? You have seen.
Yes, there are various common mistakes, like andrology lab is not separate. They are doing the preparation of the sperm inside the lab only. Main IVF lab, cryopreservation unit is also there in the same premises, not separated. No ventilation system. This all was there previously, but now wherever the scope is possible, they have implemented the new things and they have changed. But the space is always a constraint. So they have to do whatever best possible, like inside they have air cleaner, air purifier to maintain the VOC and all these things, but the improvements has been done. But this was very common mistakes done in earlier days, that like just in 500 square feet area, they used to have the entire setup of IVF lab. I have seen few labs where if two people stand together, they will definitely get collided with each other. So much of restriction of the space. So no two people can work. But now, as a rule, there are minimum 2 embryologists required. So you should have that much of space where 2 people can freely move around. So these are few common things which is there, and this can be taken care of now in the new coming up labs, because there are very clear-cut guidelines given, how much area, what areas, how much rooms required. So one can follow that.
So Shilpa, there is one question from you. What do you think about cryo storage system, that room? How we plan cryo room? How we design basically? What are the precautions we have to take care about cryopreservation room?
Definitely. First of all, I want to say that disorganized lab is very difficult to operate. And definitely we should have a separate cryo room apart from embryology lab, because I've seen there are so many labs, they have kept cryo containers within the embryology lab, which is really dangerous as well, because a small spill can affect your embryos as well. So there should be a separate cryo room, but mostly people, they are using embryology lab as a cryo room. I think that that's also okay, because we didn't kept any embryos in that. Apart from that, I just want to add one more point in that. I have seen in various labs there is no pass window between OT and embryology and embryology. So taking a long round from OT to embryology, then embryology to andrology is very tedious, and definitely it's very tiring for an embryologist to move so much in the lab.
Even I think in OT transfer, when transfer is happening, you have to carry out that catheter and move around. It is really very dangerous. So Dr. Devan, you want to say something regarding this?
I would like to add one thing.
Do you want to add
Normally,
something about the cryo room, the ventilation? How should we keep the cryo room? Do you want to add something about that?
yeah, in cryo room, obviously there should be a good ventilation, and I think even you should recommend oxygen meter also, because you do have liquid nitrogen vapors. So I think oxygen monitor should always be there. It is recommended, not always be there, but it is recommended to have if improper ventilation is there. But one thing I would like to add regarding the design of lab is regarding the semen collection room and the andro lab. I think that should be very near to each other, because most commonly what happens is like the andro lab is somewhere and the collection room is little far away or maybe on the some other floor. I think that is not desirable at all, because we don't know actually the real person is going inside for collection or not, or maybe sometime 2% may go. So I think that is very important point one should remember while designing the lab. And all other points already Rahul and they have already told us to take care.
Just to add one point here, that while designing the cryo room, to be adequate with the means one should be adequate with the total number of cryo containers they are going to keep it in the cryo room, because the number of cryo containers, againly as Dr. Devan has mentioned, that it will again have an impact on depleting oxygen. But not only the number of cryo containers, but that room to be under the surveillance. It can be under the surveillance of camera, and it should have, at some or the other point, it should have some fire alarm indicator, so that in case, because nowadays every lab is every cryo room is having some type of devices like cryosense or something, so that they can sense and give you the alarm. And when the alarm system is there, there is the chances of having spark of electricity, and there can be a danger of any fire prevalence in the cryo room. So I think with the camera surveillance and with the fire detector, fire or fume detector, it should be there adequately present in the cryo room.
And I would, can I add one more point here?
Yes, please.
Yes.
Yeah, the another important thing which I feel is most necessary now setup required in particularly in connection to the cryopreservation is the medicine and initial medication available for the frozen injuries, because I have seen so many labs, big labs, so many cryocans, handling of liquid nitrogen is very casual. And so, first of all, they should be aware of the consequences of handling liquid nitrogen. They should wear the goggles or they should wear at least gloves while handling. But very commonly, I have seen there is a accidental spillage of gas on the floor, and that creates problem in the legs with the blisters and all these things. And when they are really not aware that what to do in such situation. So I think this is also now one of the important part of establishing a cryo lab. When you are planning this, you have to plan this also, that staff should be adequately trained, and first aid facility should also be there immediately to attend it.
True, sir. Just like having instructions for hand washing, we should have instructions that, yes, in case of cryo injury, what to do, not to do. So yes, this
No,
is again an important aspect.
Rahul. The problem is what I have seen in the labs. It's not the technical person doing this. These are the ward boy or someone. They have been asked for the help and they are pulling and they are handling the liquid nitrogen. That is the problem. If it is done by a technical person, I don't think that should be a problem. But it doesn't happen. So we have to take care of this aspect also. That is what
Yes,
I
sir.
want to
In
emphasize.
many a times, in case of injury or in case of any mishap, even technical person fails to do means how to rescue that situation. They also need some instructions. They also
No,
need
sir.
some guidelines.
No, sir, that's why I said that it is not a fire कि चटका लगने से blister नहीं बना है. That's a different thing. This is a different thing. So proper address should be given, and that is possible by implementing this in training system. That okay, in something goes wrong in this liquid nitrogen, what is initial step you can take?
And how safe this can be.
Yeah.
The next.
In designing of lab, it is very important that workflow should not be interrupted. The layout and the size of lab should be according to the workload and the number of people working as concluded by everyone, and it should be user specific. So now moving towards the next thing, we have that what are the most common and preventable lab errors, and how do we design a protocol that can make our lab at least with the minimal lab errors, or without IVF lab errors, error free? How can we make our lab error free to the most of it? What are the things we should do?
I think the only simple answer is SOP. You have to strictly follow the SOP for each and every step. So being a manager, you have to make your staff understand what is the SOP, why is the SOP, and obviously that will make them understand that now lab is error free if you strictly follow the SOP. I think that is the only answer.
Exactly.
Definitely, you have to have follow SOP, and very important thing I want to tell you that incidents so many times happened with me. As you written over here, do what you wrote and write what you are doing.
Exactly.
So many times when I was doing the procedure, so sometime I miss steps. So my junior always stand by. Sir, you missed that step.
Correct.
Always stop me in between. So really, really, it is very helpful. And do what you wrote. It is very important thing. Dr. Vikram, do you want to add something over here?
Yes, sir. I want to add one thing. Sir. Choosing the consumables is also very important. Like even in images, I have seen that 4-well dish was placed. So that is difficult for some, at least for the beginners. So the choice of the consumable should be in that pattern. So it will, if we are training the juniors, it will be easier for them to adapt. So that is a very important thing, which I feel.
I also want to add one point, sir.
Yes, sure.
Please.
I think the lab manager or the senior embryologist should be kind enough to the junior embryologist. If something goes wrong, they can come to you and tell you that this thing happened. Otherwise, with the fear of that, maybe they'll shout or something like happen. Sometimes they ignore saying you, and this will lead to a big.
Yes.
I think can I say something here?
Yeah, please.
No, what Dr. Shilpa is saying is correct. That what I call it as an intercommunication amongst the staff. It's not only the junior or senior embryologist, it is even the technician or any laboratory person, or for that sake, even the person who is cleaning the lab. They are all equally important, and they should have that confidence in the lab director that, okay, if something goes wrong and we have done some mistake, it will be taken not that seriously, and we will be communicated and all. And the best part is, as Dr. Rahul and all are saying, that nowadays it is a matter of SOP. If you have a clear-cut protocol written, and if the staff makes a mistake, then definitely they should be asked for, and they should be given whatever is their protocol, accordingly the punishment for that. And the second important thing is that junior embryologists should consider themselves as junior, and they should listen to the senior. That is another important area which I am seeing it's lacking actually, and it is creating a problem. Means they start feeling like that we have done the course, we have done the degree and all these things. So why we should listen? But you see, all of us experienced people like Dr. Ved. Last 20 years, whatever has been learned, that is the thing which is earned today. No one can teach you in a day or two, or in a year or 2 years. So it is a matter of experience only, and that comes with the working under some supervision. So that is what I want to say here.
Sir, do you think that traceability is also important when we talk about an error-free lab?
Yes, because ultimately, if traceability is not there, then how you are going to conclude and how you are going to improve? So you have to find the problem, where the problem is, how this mistake is done, and the most important part is, in spite of means instead of scolding and giving punishment and talking harsh, you have to find the way that this should not happen again. As a lab director, your responsibility is that incident should not happen again. So what measures you can take for that you have to see.
I think Dr. Paresh is also there. Dr. Paresh? Dr. Paresh, are you there?
I think meantime, I would like to add one thing.
Yeah, please.
Regarding the mistakes, I think if it is always good that the your embryologist come and report to you, this will actually help to improve the SOP. So just for example, I can give very good example that normally when we do ET and when we check the plate, there is like after ET, we again cross check the ET catheter, and very rarely we get embryo back. But sometimes because of some mucus or some blood, you are not able to really see that, and maybe you just discard. But then very rarely we have found that okay, that same plate is checked by the second person, then maybe even you are not missing even that 1% chance also. So then you need to improve your SOP. So these are lot of other examples, but yes, this is one of the example which can point that okay, if we really want IVF error free lab, these are the small things you should implement in your lab. So encourage the juniors to come and tell you if there is any.
Double witnessing is important.
Yes.
Do you think audits and regular compliance check is also important if you want to make an error? Because we can always have instrument failures, and because we are doing a regular quality management or quality assurance and checks. So it is also like have to add with the regular audits and the compliance checks. They also play a role in this or not?
Definitely, I would agree that yes, there should be regular audits, and obviously you should call the engineers for, or at least you should have AMCs with the companies. But I think along with this, I would like to add one more thing, that there should be one technical stop in a year at least. So there you should be stopping all the instruments, cleaning them properly, then again restart them after cleaning, and then call the engineer and check, and then again you start. So I think this is the one thing which a lot of labs are missing. Like they are continuously working, and we are happy that okay, AMC is there. Like engineer comes and then engineer checks the instrument, and we are all happy. But I think proper cleaning, where normally you will not go and really clean the incubator. So these are the corners are there. Certain corners you will not do in routine. So I think technical stop is very important. I think you should add that point also here.
Yes, sir. The internal and both the internal and external audits, the one you are doing with the help of your team, and one you're doing by calling somebody else in the lab, the third party audit.
Correct. Yeah.
Anyone else?
Yeah, I think the quality management, I think QMS will not function properly until unless there is an incident reporting pattern developed or framed within the lab. Because many a times we know that this equipment is not working. Everyone knows that this equipment is not working, but there is no reporting. There is no document proof of it, that yes, this equipment was partly used, or it was not used completely. So there should be a proof of it. There should be a document of it. Yes, that this was the incidence. There was the low CO2 pressure in this equipment. This basically a rescue portion was being done by the embryologist, checked by the senior, and then the company person was called. So yes, there should be a proper incident reporting pattern, that it will actually help you to develop and frame your KPIs, that how your KPIs were fallen in those duration, whether there was a fall seen with the pregnancy outcome, with the beta HCG outcome rate, or something with the embryo blastocyst, anything related with the KPI. So there should be a proper incident reporting pattern. I think with this, quality management system will work very completely in a very smooth manner.
Very well said, sir. Working in compliance with quality management system is actually mandatory. We have to take care of all the record keepings. Format should be a proper. There should be standard SOPs, quality system procedures should be there. So there are 3 steps: maintaining quality management, then implementing it, and then establishing it. All the 3 points are very important when we talk about the error-free lab. So moving towards the next question, sir. Do you want to take the question?
Then you can continue. I'll there.
So IVF Lab, they invest heavily in air quality control system. So just want to add a thing that just want to ask a thing, that what is the most effective protocol to minimize VOCs in the lab, inside the embryology lab?
Can I start?
Yeah, Shilpa, definitely.
So I think, yes, definitely VOCs affect the embryo formation rate. And there are certain papers that says higher the VOCs or more the VOCs is really going to affect the pregnancy rates and the embryo development rate. And how can we minimize the VOCs in the lab is there should be less people in the lab, as less as possible embryologist and a junior one. Plus all the disposables, if required, we have to keep in the embryology lab. It should be minimum disposable that should be cleaned outside the lab, and very less furnitures, wooden furnitures and all should be there in the lab. So we have to avoid as much as we can, because a small increase in VOCs definitely will gonna affect a lot.
Devin sir?
I think one thing I would like to add is to reduce the VOCs, basically hand washing and then no flowers, no spray and all. That is like most commonly we all know. But for laboratory perspective particularly, I would like to emphasize that the plates which you are using, that should be opened, the sleeve should be opened and the plate should be kept for at least 48 hours before using. So that will also release VOCs in the air, and then that will not go into the culture system also. So I think that is not commonly followed by many labs. So normally we just open the sleeve and we start using the culture plates. So I think that one should not do that.
And just to add one more thing to it, I think very well mentioned by Shilpa and Dr. Devin that yes, these are the precautionary things one needs to take care. And what I want to mention here is how your air ventilation system working in the lab, how fresh air is being pumped inside, how your means residual air being sent back to the air ventilation system, and how this filtration pattern is working on, like how your AHUs are working, what kind of filters your AHU have, what filters are being cleaned at what interval, means you have cleaned the filter, you have replaced the filter. All these parameters again can play a very huge role, because many a times we see the ductings in the AHU, it is being flooded with fungal infections, it is being flooded with some of the other construction material. So all these pattern needs to be taken care, and they can be avoided with proper cleaning, proper patterns of your cleaning of filters and AHU systems also. I think the AHU will ultimately remain the untouched and very less covered part of your foul air within the lab. And it is again an important aspect where you might not be looking forward for increased VOC in the lab. So AHU is again an important aspect to control your air.
So there are, that Coda Tower
Yeah. Yes.
is there. So do
Yes.
you think they will actually, that if there is no AHU system,
Yes.
will that Coda Tower will help in
I
that
not
situation?
only the Coda towers, there are the filtration system which works with UV carbon filters, having proper HEPA filtration units. So if Coda tower is giving you something like this, that there is a UV system with carbon and with HEPA filtration. So I think yes, this is the desirable thing that one can have in the lab. Nowadays, I think there are some units, air handling units, which are like just like a plug and play system. They are the systems of potassium permanganate, alum, carbon, and with HEPA filtration. So they are to be attached just near to the lab where you are keeping your all equipments related to cylinders, your UPS. You can install it over there, and not having a proper ducted AHU system. So these kind of new advancements, new technologies that can be implemented or that can be installed in the lab, and ultimately their cleaning pattern, because the smaller the unit for the air filtration, the routine and the more cleaning protocols to be taken care of. Means if it's inside the lab, it should be cleaned monthly. the AHU is means installed over the lab, it can be cleaned like 3 months or 6 months. So you have to frame your own cleaning protocols, that when the filter, when the system is going to be cleaned and how it is going to be cleaned. So again, this will be an important aspect for VOC.
There are certain equipments are available in the market now that measure the environment VOCs count, and that will give you alarm if the VOCs increases. So this happened. I'm going to share one of case. We have a equipment with by Shivani Scientific. So generally it gives alarm at 8 a.m. in the morning when we are not there in the lab. How can there is increase in VOCs when we are not in the lab? So it keeps on giving alarm 1 day or 2 day. Then I retrospectively checked that how can it gives alarm. So we came to know that there is a new housekeeping staff and she don't know that how to clean lab. So she is using that surf detergent and all and wiping out everything in lab. So thank God with that instrument we'll be able to know, and we could stop that. Otherwise maybe this is gonna affect our embryos.
Yeah, right. Good. Good. Actually, this really it is helpful because sometimes there was one lab I was working over there. In the morning 11 a.m. the VOC increased, and I always speak to them that there is something problem here. Nearby something is happening. At 11 there is something is going on. So when I inquire surrounding area, I came to know there is one restaurant. They start cooking their food at that time. So VOC increased at that time.
Interesting.
Yeah.
That's why it is very important to take care of the surrounding, also to know
Yeah.
what make that increase and how to handle when there is an increase in the VOC.
Yeah.
So I think all of us have a few stories about how everything increases in the lab and how it affect the quality of the lab. Now moving towards the embryo culture system. So just like Goldilocks, we all want everything just right for our culture systems. So how do we balance oxygen concentration, pH and temperature fluctuations to avoid embryo stress? And how do we get all these things just right for the embryo development? So we have to talk about the pH, temperature, what should be the optimal numbers, and how do we have to control it if something goes wrong.
Okay, so maybe to start with, if we are talking about oxygen concentration, I think it is now well studied and lot of papers has recommended for lower oxygen. So at least less than 5 or at least 5. But not in 20%, not atmospheric oxygen. I think that is the first thing one should remember. Regarding pH, yes, it is already written in brochures of the media, like 7.2 to 7.4. So you have to adjust your CO2 concentration to make it come into the range of 7.2 to 7.4. But particularly, I'd like to work with 7.2 to 7.3. I think the results are really good when you have 7.2 to 7.3. And coming to the temperature, yes, all your heating plates or the laminar airflow heating area, that should be maintained at least 37 or little bit above, but never it should go below, because the lower temperature is definitely going to hamper the cell divisions. So broadly speaking, yes, these three things you can handle in the lab.
Dr. Rahul?
Yes. So according to the question, I think gases and pH, these to be monitored and checked separately with the temperature. I think temperature is one aspect that you need to take care that at what and which temperature your embryos are giving good result. Means there are the studies and there are the papers that they have slightly deviated to a lower temperature, like around 36.5, at which the embryos and the blastulation rate is on the higher side as compared to what we see routinely on 37-degree temperature. But yes, temperature is again an spatial part, and it needs your further interventions, because temperature not only start with your culture system, it start with your surface temperatures, room temperatures. So everything is related to temperature. And other part which is related to gases and pH, yes, Dr. Devan has very rightly said that around 7.2 to 7.4 of the pH is the adequately properly monitored pH to be maintained within the embryo culture system, can give you better outcomes. You can have pH manipulations or pH calculations using various pH meters which are there, and even with the ABG gas analyzers, so that you are on to the optimum ranges of pH during the culture system, not only during the course of embryo development also, but also to have adequate rate of embryo development throughout the month or the duration when you are working in the lab. So yes.
Dr. Vikram?
I think one more important aspect to this, that we should try to give a single patient to a single chamber. So by doing so, we'll be able to minimize the variations in temperature, CO2, O2. So that will be very helpful. And even that there are many reports that, as everyone have said, that variation in temperature and CO2 that affects the plastulation rate. So we try to give one chamber to one patient, so we can minimize the opening of the chamber, so which will provide the optimal culture condition to the embryo.
Right.
Dr. Shilpa, do you want to add something?
I think everyone have elaborated enough, so nothing new from my side.
I would like to add one thing. So regarding the equilibration of media, if you are culturing the embryos in low oxygen, then one should not equilibrate the change dish into the Hera cell, basically that is 20% oxygen. You should always equilibrate your media in low oxygen if your culture system is maintaining that low oxygen.
Yes, sir. So we have talked about there are multiple factors which impact the microenvironment of media. Everyone has described everything very beautifully. Now moving towards the next thing. Now we in a clinic we have reported a sudden decline in the blastocyst rate. Now, can you please walk us through your detective process? Where do you start the investigation first, and what are the steps you are going to follow throughout? Anyone can
First, I do check the quality of the gametes. If it is like first to rule out if it is patient profile based declination, and if it is there in like almost all the cases, then we have to check for the changes of the cylinder, like when the cylinders were changed, CO2 and nitrogen both, and we need to check the timeline that okay, when we are seeing this declination, then we need to check, go back to the media, then everything has to be cross checked again. Media, then if any construction work is going on in the vicinity, like if some paint work is going on or not, or if there is like in what happened in mainly in the rainy season, what happens, the humidity also goes very high, so sometimes HUs doesn't work properly, or there is a clog in some kind of the filter, so again which will affect the air quality in the lab. So all those points we need to check again, and the most important thing in this, if like the like from the summer to the winter, so outside environment's temperature also goes down, so we have to calibrate our machine again during that time. So we need to check, even though display temperature is 37, it might be above or it might be below. So during between this seasonal changes, we need to check all the machines needs to be calibrated.
So we have gathered all the initial data that what is making this decline to start. Now, what should be the next key steps which we have to take? Devin sir.
So obviously, like once you find out that what was the issue, So just for example, if it is a culture media, then obviously you need to really check, go back, and again, if the same bottle is available, you can check the pH, or you can check the expiry and what is happening, like previously discussed, what is happening in other lab with the same media, if it is the media. So same thing with the oil. So just you first identify the problem and then you work on that problem. So if it is not broad based and if it is patient specific, I think you should talk to the consultant, and then you try to find out that what kind of hormones were given, so based on the quality of the gametes, or maybe the sperm count was very poor, or maybe the high DFI was there, so then maybe you can plan TESA in the next cycle. So based on what the problem was, I think you can change accordingly inside the lab.
So it is very important that implement corrective actions and then monitor that everything is going fine again or not. Dr. Shilpa, do you want to add something?
Yeah, just want to say that yes, being an embryologist, we always start from an embryology lab. So keeping all the embryology factors normal, we will definitely check where the decline starts, whether it is day 3 or day 5. Checking all the culture condition, media conditions, we have to retrospectively analyze the patient's profile and the clinical parameters also.
Very well
So you
concluded.
have to have documentation, proper documentation for that. So you can check easily. You can make out that where the problem is.
Yes, gathering all the initial information is very
Yeah.
important. For that step, you will realize where we are getting all these things wrong. So if it is a patient factor, we can see the biological contributions, whether it is a sperm factor or the oocyte factor. And after looking into it, what is the problem? We can implement all the things and we can take the corrective measures and then monitor further. So monitoring further can take us to the KPIs. So according Dr. Nidhi has already explained very well about the KPIs we have, how they work, and how competence and the benchmarks are there. So now just elaborating that question, we have what are the most overused or possibly misleading KPIs in IVF lab today? What do you think are the most overused KPIs in the lab?
To be really broadly speaking, first, I think you should understand, or you should go through the KPIs properly. So properly, what I mean to say is that you should consider what kind of patients you are considering. So if you go through the paper, in that it is clearly mentioned this is not for in general patients. So if there is PGD cases, TESA cases, you should not consider that patients for KPI, or the patient having more than 38 age. So there are certain conditions where you should apply your KPI, and that too with particular number, so that they have mentioned at least there should be 30 patients data should be there. So if it is like small center with only 10 patients per month, then obviously that month KPIs should not be working properly, or you should not consider that properly. So that should be at least 3 months data should be there, so basically 30 patients, and then you should apply your KPI. So if you apply KPI very broadly, definitely it is going to mislead in all the areas,
Yeah.
and it will be very difficult to really analyze what has really gone wrong in the lab. And if you ask me regarding the what is the most overused, I think overused is maybe fertilization rates in general, where we see that okay, the fertilization rates are really going good, but before that, the important part is maturation rate also. So if the maturation rate is poor, definitely you are not going to have very good fertilization rate. So, but then obviously, clinician or maybe even embryologists also always see that okay, my fertilization rates are really good. I think that one should understand for using the KPI.
So one thing which Devin sir has told is one of the best take homes we can take, that KPI is not for all the patients, it is for the particular set of patients, that you have to consider that it is not for everyone, and read the KPIs carefully, so you'll get all the details in that.
Yeah,
So now
definitely. And even if the number of cases are very less, then definitely it will not help you. So you have to have minimum 30 cases, as Dr. Devan has already mentioned. Then you can able to see the changes or how you are doing in the lab.
So now, should a dip in KPI triggers the panic inside the lab? If we see a sudden dip in the KPI, should it trigger a panic inside the lab? Or usually we see that clinicians get panicked when we say there is a dip in KPI. So what are the scenarios where we see this dip, and what should be the corrective actions to be taken?
Dr. Vikram.
Yes, sir. According to me, it it can go both way. Like it can trigger panic also, and if it is justified, like if we see there is a decline in pregnancy rate or decline in blastocyst rate or decline in fertilization rate, then we should go and check the each case individually. If it is justified by their clinical profile, then it's fine. And if it is not, then again we have to go through all the QAQC and traceability of the media. Then we have to find out the cause. If it is justified by the patient, or if something happens with the drug, what happens in recent times, what I have seen, that all the machines and medias are very stable. If you are using a particular set which you are using for the longer time, they won't give you sudden decline in any kind of the KPI. The most important factor is the drugs. So each lot of the drugs is again giving the poor quality of oocyte. So we need to take care of that part also. We need to check the clinical profile also, and what was the quality of oocyte. Because if the quality of oocyte is bad, like if suppose if FSH media's FSH drugs lot is not good, and patient stimulation is being slow, or there is a low recovery, then ultimately it will affect the whole of KPI. So we should have an answer for dip in the KPI, and if it is not, then we have to check for each and every lab parameters.
Yeah. Dr. Charu.
Yes, I have an opinion on this. Is that KPI? So basically, the problem is as soon as there is something was wrong in the results, immediately everything start thinking about the laboratory, and there is some problem in the lab. Only KPI is not working and all. We all know it's a multifactorial system. And you cannot just by making one parameter correct, and you will see sudden increase in the pregnancy rates. So, in my opinion, if there is a dip in KPI, it should not trigger panic. You should be working out systematically, stepwise, one by one, sort out the issues related with it, and then you will reach to a conclusion that okay, this may be the reason behind this. You cannot generalize that, okay, this KPI is going down, so there is some problem with the quality control, as rightly said by others. It may be due to some other reason, it may be due to drug also, it may be due to anything. And what I feel is that in a running lab, if a lab doing daily cases, they are having so much of quality control and everything. So usually these KPIs like pH, temperature, it should not be a problem because they are regularly monitored. The thing which is not monitored regularly, that we can focus on to see why there is a dip in success rate or dip in KPI per indication, something like that.
Deven sir?
Yeah, I would like to add here one thing is like I myself has experienced like in one of the center when I was working previously, when I was visiting some center, and like embryologist was really complaining about the oocyte quality. And I agree with Dr. Vikramjit here that then when we really went to the pharmacy and when we checked the temperature of the refrigerator, because lab is always checking their refrigerator temperature, which was falling in 2 to 8. But unfortunately, the temperature of the pharmacy was running beyond 15 degrees centigrade, and then we were able to point the culprit that okay, the hormone might be having the problem. So I definitely agree with Dr. Vikramjit and Charu sir. And second thing regarding KPI dip, I think you have already shown in the photograph a picture here that if it is plus or minus 2 SD, then definitely I am working really worried something is wrong in the lab. If it is near to plus or minus 1 SD, maybe I'm not really worried.
Yes, so this is very important that the dip, how much dip is there, that is very important to consider. If there is a dip, you can work on it. But if there is a sudden dip, as we can see here in the 12 days, so if there is something like this, which is lower than 2 ST limit, then definitely you should panic. You should
Yes.
see what is there, what is wrong in the KPIs and what is wrong inside the lab. But there are, it is, as sir said and Charu sir also said, that it is a multifactorial thing. You cannot blame on only one thing. You have to rule out what else we can do and where else we can be wrong. We have to take care of everything. Wait, sir.
Next.
Yes,
Yeah.
okay.
I would like to just add one more thing also regarding the KPIs and regarding even media also we discussed. Normally, we consider that, okay, the pH is perfect. And then okay, that media is like working perfect because the pH is perfect. It is not normal, because if it is like in my lab, all the patients are having slow growth of the embryos, then even if the pH is right, I think you should not consider it as the media is perfect. You should see overall growth also. If it is all slow growing are there, definitely media is not working well, even if the pH is perfect.
You're right.
This is same with the day 6 embryos also. If we get more of the day
Correct.
6,
More of the day 6. So this usually we have seen when the media batch is near to the expiry. So normally we get something around 12 to 13 weeks to work, or maybe at least 7 to 8 weeks to expiry. But if you get the media which is just about 3 to 4 weeks, just maybe 1 month to expiry, yes, definitely I have seen there is a real drop in the blastulation rate. And even in the thaw media we have seen, like normally it is 1.5 year expiry, but if it is near to just 6 months near to the expiry, we have really seen very poor pregnancy rates also. So you have to really watch all the data.
okay, now considering the time, I'll only take this question last, and then we'll wind up to the rapid fire, and then we'll close. So there are some policies, that there are strict policies that we should go for the blastocyst transfers only, not considering the other things. So in a perfect or decent lab, in which scenario would you prefer a cleavage stage transfer over a blastocyst transfer, or you will never? What is your take on this?
I think we will prefer the patient age is little higher side, maybe 40, 42 age is there. Definitely we will prefer a cleavage stage transfer, or
There
at
is
least we
no
will
strict
freeze one
policy.
embryo and then other embryo we will allow to grow to blastocyst.
Okay. So there is no strict policy. It
No.
is all patient dependent. Okay, Dr. Shilpa?
Yes, definitely it's patient dependent. And if it's a new lab, definitely we'll start with half and half. We'll keep half day 3 embryos and we'll follow half for blastocyst if it's a new lab. And if it's a regular lab, definitely we'll prefer doing blastocyst transfer for all.
Okay. Do we have any other? Dr. Charu sir?
I think it is patient dependent. We have to see the number of embryos available, the quality of embryo, and so there should be no strict policies for this as far as embryo transfer is concerned. But yeah,
as Charu sir already mentioned, and everybody maybe agree with me that there should not be any strict policy, because sometime what happened day 3 transfer we have to do because of that embryos are not good, and patient are going somewhere, maybe they are traveling. So sometimes we have to do these kind of things. But definitely we have to prefer blastocyst transfer. It gives good result. But as and when required, we can do transfer on day 3 also. So sometime we have to think about that. This is my take. Yes, Dr. Devan, you want to say something?
One more scenario, like if blastulation rate is really dropping in your lab, it would be really
You are
preferable
right.
to freeze few embryos on day 3. So something is really wrong. Maybe in case of sequential media, so blastocyst media maybe is not working for whatever reason. Media is not working properly. So it is for safer side of the patient, you should really freeze few embryos.
Yes, definitely.
So there should be a policy, but not strict enough to just divide these patients. Like we should also consider the patient factor. If there are other things which can affect the outcome, we can go with the cleavage stage transfers also.
Yes.
Just skipping all this because we have already discussed this. And coming to the rapid fire, one word answer or one line phrase for everyone. One lab habit that makes all the difference. Devin sir.
I think follow SOP.
Perfect.
Good.
Next, Shilpa, if you had a ban, if you had to ban one outdated IVF technique, what would it be?
A3 transfer.
You want to, and Abhi, you said there should no.
I said I do blast for all.
Policy. Now you're saying that.
I said I do blast for all.
Day
If
two
it's a
transfer.
new lab, then only.
Then only, okay. Okay, we'll take that. What's your non-negotiable rule for embryo handling, Dr. Vikramjeet sir?
Mainly for multiple pipettings I don't like. Even while washing also, the embryos, we should minimize using the pipetting. Like I have seen many labs, like they wash the day 3 embryos in 3-4 different droplets, then they transfer to the blastocyst media. Then that should be not there. Embryo should be minimally managed.
Charu sir, what's one myth about embryo culture that needs to go?
Measuring pH and other parameters every day, that is something which I don't like. It should be done periodically in a systematic manner. Because just by measuring pH, your embryos are going to be very great. It's not going to happen. pH is something which needs high precision instrument and a qualified person to perform it. That is what I feel.
Okay, I don't see other members of the panel on board, so I'll repeat the question I'll repeat the question to Deven sir.
Rahul bhi hai. Rahul is there.
Rahul sir said that he'll leave.
Okay.
He's just listening, I think. One word to describe the future of laboratory, Deven sir.
I think AI.
Yeah, perfect. Closing with this, there was a beautiful slide shown by Dr. Nidhi that the TQM is a necessity, SOP is must, QC/QA should be regular in the lab, KPI is a guide that can help you throughout, and embryo development is multifactorial. You cannot just consider on one factor and get the best things. So for best practice, for best result, you should have the best practice in the lab. Thank you so much and happy Holi, everyone.
Thank you. Thank you. Thank you so much, each and everyone. It was nice discussion, and I think everybody's contributed very well. And thanks to Dr. Jyoti for organizing this all, and all the Haryana teams. And thanks to that Jackson Pal. And happy Holi to all. Thank you so much.
Thank you, everyone.
Over to Dr. Jyoti.
Thank you, everyone. Take a minute of yours.
Thanks.
Thank you all for joining in today. This session today was brought to you by Jackson Pal, Nari Division and Fembond Division, where we have Cysteria M, Divatron SR, and Lycored tablets. And it was also an initiative of My Sakhi, that is the CSR initiative of Jackson Pal. You can log in and to our website, mysakhi.in, and update yourself about
Thank you,
CSR.
Dr. Deepika. This is Dr. Minu Handa. I'm sorry my camera is not functional at the moment, but thank you so much. Thank you, Dr. Charu sir and Dr. Ved sir, for such an elaborate discussion. Dr. Nancy, you did a fantastic job in moderating, and I think all the esteemed panelists contributed so well. So thank you so much from
you.
ISAR Haryana team once again.
Thank you. Thank you.
Thank you. Yeah,
Thank
Dr.
you.
Ved sir, Dr. Charu, Jyoti this side. Even actually I am driving. That is why my camera is also not on, but we really enjoyed the whole. I was there throughout and it was excellent. So, and Dr. Sharma, I mean, very nice. The panel that you carried with Dr. Ved sir, it was wonderful. And all the panelists were too good. I mean, the practical tips from their daily practices that you've shared with us clinicians, it is amazing. So every time we make small
Yes.
little mistakes, we don't.
Totally. I think now more and more clinicians are also joining in to always hear the secrets of all the embryologists. So thank you, Dr. Ved sir and Dr. Charu.
Yeah. Thank you so much, sir.
Thank you.
Thank you,
Thank you.
everybody. Thank you,
Thank
Dr.
you.
Deepika and Jackson Paul.